Hi, my name is Chester. Today I'm going to be performing a focus abdominal assessment. My patient is Mitchell, is a 35-year-old male. I've already done my history. I'm going to go in and introduce myself and get consent for the abdominal assessment. Knock, knock, knock. Hello, my name is Chester. I'm going to be your nurse today. Are you Mr. Mitchell?
Hi, Chester. Yes, I am.
Hi, Mitchell. How are you doing today?
I am well.
You're well, good. Well, today we're going to be performing a little abdominal assessment, which basically means I'm going to look at your abdomen and listen with my stethoscope here. I'll have to push a little bit on your stomach and make sure that everything's okay. Is that okay with you?
Okay.
Great, great. Well, first of all, I'm going to need you to take your shirt off. I'm just going to wash my hands here.
Okay.
Okay. I'm going to ask you to lie down on the bed, please.
Okay.
First thing I'm going to do is look for the contour, the symmetry, shape, any pulsations or peristalsis that would be noticeable. So first thing that I notice that he has symmetry about the midline on both sides, right and left side. And I'm just going to get down here a little bit eye level, just above to look. I don't see any abnormal masses or anything that would indicate abnormalities. No pulsations, no noticeable peristalsis. Going to have another look at the feet again. If I wanted to, I could use a light and shine it over to see any kind of shadows which would indicate a mass or any kind of abnormalities in shapes which would make it asymmetrical. You can do that by going across laterally here or even from the head with a light this way. Skin tone is even, it's homogeneous, appropriate for his ethnicity. I'm going to now ask you to, Mitchell, if you could do a sit-up for me without using your hands, okay? Great. Go ahead and lie back down and do one more sit-up for me. Excellent. And I asked him to, you can lie back down now, Mitchell. I asked him to do this type of sit-up so I could see if there were any abnormalities or masses that were noticeable when he was sitting up that might have not been noticed when he was supine there. I'm also now going to, I also noticed about his hernia, his umbilicus, that there's no hernias. His umbilicus, or belly button, that's what we call belly button, Mitchell, is not everted. It's inverted like it should be. Have you been having any abdominal pain or issues with your bowel movements?
Other than my IBS, no.
Oh, you have IBS.
Yes.
Is that something that flares up every day, or how often would you say you have bouts of IBS attack?
Every couple of weeks.
Every couple of weeks. Okay. Have you seen a gastroenterologist?
Yes, I have.
Okay. And what do they tell you to recommend for symptoms of IBS or how to cope with it?
Eat better.
Eat better, okay. So what does eat better mean to you?
Eat better than I did before.
So what is your daily diet consist of now?
A whole bunch of junk food.
A whole bunch of junk food? Well, I don't know if you could eat worse prior to that, but it's probably recommended that you eat lots of fruits and fresh vegetables, whole grains, lean meats, stay away from the excessive fats and excessive caffeine. But everybody's IBS is a little different, and sometimes stress can actually activate those kind of GI symptoms. So reducing stress in your life too is important. Now I'm going to go ahead and listen to your stomach. First of all, I'm going to listen to his bowel sounds, and then I'm going to listen to his aorta for any kind of bruits, which are whistle-like, pulsative, blowing sounds. that would indicate occlusions or stenosis of the arteries. But as we know, if an artery is completely occluded, you're not going to hear a bruit because there's nothing going to be flowing through there. So I'm using a digital Lippmann, and I can put the bell and diaphragm on at the same time, or either or. So I'm going to start in the lower right quadrant. And vowel sounds are gurgling, high-pitched sounds. They should occur every 5 to 30 seconds. And I'm going to move up to the right upper quadrant. And while I'm doing this, I'll go ahead and start listening to his aorta for any kind of bruits, which I'm going to listen in the epigastric, about the midline and the mid-abdomen here. You can also listen for my renal arteries and my iliac arteries and my femoral arteries too. Okay, normal active bowel sounds. They weren't hyperactive, which is good. I guess you're not about to have an IBS attack. And I did not hear any bruits at the aorta or at the renal or iliac or femoral arteries. So the next thing I'm going to do, Mitchell, is that I'm going to percuss your abdomen a little bit, which means I'm just going to tap around, and I'm going to be listening. And for the better portion of a normal abdominal assessment, you're going to hear tympany sounds, being that air from the intestines rises up, and that's what you want to hear. Now, if you start hearing dull sounds, it could be fluid, it could be fecal impaction, or just feces in there, it could be a mass, or anything that's going to make the sound sound more dull. But for the better part of the abdominal assessment, it should be tympany. So I'll start on the right side. So I hear some dull sounds in the lower left quadrant, which is probably indicative of some fecal mass in there, which is not an abnormal finding. But for the majority of the abdominal assessment, for the right, lower, upper, and left upper, I heard tympany sounds. Now for the next portion of the exam, I'm going to go ahead and do a little palpation, which means I'm going to touch with all four of the pads of my fingers, and I want to palpate the liver, because we always want to look for any kind of liver enlargement. Now for this, I'm going to take my left hand behind Mitchell's rib cage at around the 11th or 12th rib, and I'm going to push up so I can support the abdominal contents. And then with the right hand, I'm at around the 11th or 12th ribs, I'm going to push deeply under the costal margin here and ask the patient to breathe slowly. Breathe slowly, please, Mitchell. And then I'll inch my way up on inhalation. And you shouldn't feel more than 1 to 2 centimeters of the liver, which I did. If you feel any more, that means the liver is enlarged, or if the patient says that it's painful upon palpation. Now, if it's enlarged, you want to note how enlarged it is, estimate, and then refer to the doctor and specialist for further workups. Now I'm going to palpate the spleen too. And if I was going to normally do this, no, under normal circumstances you don't feel anything with the spleen. You shouldn't feel any firmness or ridges with the spleen, but if it's enlarged and approximately 3 times the normal size when you start feeling it. Now the spleen can get so enlarged that it goes down into the lower quadrant, but if you do feel an enlarged spleen, you need to stop immediately and stop palpating it, because spleens are very friable and they are prone to burst, which you would not want to do because that's an emergency situation. So for this, I'm going to reach over the patient with my left hand at the 11th or 12th rib, and then with the right hand at the 11th or 12th, oblique to the midline. I'm going to ask the patient to take a deep breath, and then I'm going to push firmly down. And nothing. And that's a normal finding. You didn't feel anything, so that's good. And lastly, I'm going to palpate the aorta. And with this, I'm going to take my 2 opposing fingers, my thumb and my pointer, and about the epigastric mid-abdominal region above the umbilicus. I'm going to push firmly, and it's a little bit to the left of the midline that you're going to be doing this. Push firmly down, and I'm going to feel the pulsation of the aorta. Now normally the aorta is 2.5 to 4 centimeters wide, and the pulsation happens with exhalation, and it's anteriorly. Now if it was abnormal, that would indicate, possible aortic aneurysm or some type of portal hypertension, and it would push your fingers out laterally. And you would definitely want to refer this to the doctor and get something done about that. And that's the end of the abdominal assessment. Thank you very much, Mitchell.